Hi everyone, welcome to Miss Medic. Today I'm going to talk about hearing loss, which is a really common presentation. And on the ward you will often see many people with profound hearing loss. They may ask you to repeat what you're saying, and some may even ask you to pull down your mask. But do you ever think why they have hearing loss? And it's a good idea to think why they have this hearing loss when you're in with these patients, because in OSCEs you will be presented with patients with hearing loss and expected to get to the bottom of it. So whenever you see someone with hearing loss on the wards, it's useful to think of it as whether it's sensorineural or conductive hearing loss. And that is something I will be talking about in the next video, so do keep an eye out for that. In this video, we will be talking about a very, very common presentation in the land of GP. It's not to do with an elderly patient, it's to do with a very young patient, a 6-year-old boy. So this is our case today. You are a GP trainee and a 6-year-old boy, James, comes in accompanied by his mum, and she is very concerned about possible hearing loss. So the first thing you do is you want to take a history, and with every history taken you of course introduce yourself, wash your hands and ask their name and date of birth. And then you must always begin with an open question. If you don't, you will possibly lose marks from your examiner. So you want to ask James' mum to tell you more about this, what's going on. So his mum does comply, and she tells you that James has become listless. His teachers have been saying that he isn't paying attention in class, and at home he often turns up the TV. So she's very concerned there's something going wrong with his hearing, because this is out of character for James. Now you want to go into more specific questions. So you would like to ask what ear it is. Is it both ears? Is it one particular ear? And his mum tells you that it's his left ear. You would like to know when did it start. This is important, as it could be a sudden loss of hearing or it could be more gradual. And James' mum tells you it's been gradual, it's been going on for the last week in particular that she has noticed. And you also want to clarify whether there's any ear pain. And his mum tells you that she has noticed him tugging a lot at his left ear. And sometimes children won't say they've a pain in their ear, but you will see them tugging, which is a sign that it's painful. Now, here are some other questions you could ask when taking a history from someone with hearing loss. So, any ringing in the ear, so this is tinnitus. Any discharge from the ear, any exposure to loud sounds or any foreign bodies, any sensation of the room spinning, so vertigo, or any loss of balance, and any infections or fevers, and any sensation of fullness in the ear. So James' mum says no to the first 4 questions, but she says that James often has respiratory tract infections, and James himself says that his ear does feel full. So we move on, and you want to ask about past medical history, social history, drug history, and family history, as you would do in all other history takings. And also, as this is pediatric history taking, you'd inquire a bit about immunization, birth history, and then ideas, concerns, and expectations, summarize, and of course thank the patient. Very important also. And the next thing you want to do is investigate. So you're going to look at James's ear, and you're looking with the otoscope, and basically you want to see what the eardrum looks like. And it's important to know what a normal eardrum looks like. So here on the left we have a normal healthy eardrum, and you would see the handle of the malleolus and the cone of light. So it's important always to look for this cone of light. It's anterior inferior position in the ear always, and when you're presented with an image of the back of the ear, this can help you determine whether it's the left ear or the right ear, because in the right ear this cone of light will be in the 5 o'clock position, and in the left ear it'll be in the 7 o'clock position. So that's a useful marker to know if in the exam you were presented with an image, to know whether it's the right or left ear. So you want to comment on the colour of the eardrum and whether the cone of light is present, that you see the handle of the malleolus. The eardrum should be normally flat, but when you look into James's ear, you see that there's a fluid level in the ear, and the tympanic membrane, which is another term for the eardrum, is indriven. So the next thing you decide to do, you see that the tympanic membrane is indriven, that there's a fluid level, and the eardrum is quite a dull colour. So you decide to do an age-appropriate hearing test for James, and you also order a Tympanogram. So this is a very important test to do, the Tympanogram, and it's useful if you're suspecting a problem within the middle ear. And we do suspect a problem within the middle ear. We suspect that he has glue ear. And indeed, when we do the tympanogram, we see that James's tympanogram is very flat, and it normally should be a curve shape, like a normal age distribution curve, bell-shaped curve, but his is completely flat. And this suggests that James has otitis media with infusion. So you say this to James's mother, and of course she has a lot of questions. She's never heard of this condition. She wants you to explain it, and you tell her that otitis media with infusion is another term for glue ear, and that it is a very common cause of hearing loss in children. And in fact, by the age of 10, it is estimated that about 80% of children will have at least one episode with otitis media with infusion. And there's many risk factors for this condition. It's more common in male children. It's more common in children whose parents smoke, children with cleft palate, with respiratory tract infections, and children tend to get more in winter months. So the problem with otitis media with infusion is that the middle ear is not functioning as it should. So the middle ear tends to be just filled with air, and it connects the outer ear to the inner ear. And the middle ear also has a very important structure within it known as the eustachian tube. And this eustachian tube is normally closed, but it opens sometimes when we're yawning or chewing or swallowing. And this lets fluid out, and it helps to stabilize the pressure within the middle ear. Now, with otitis media with infusion, there's normally a problem with this eustachian tube. It's not working properly, and therefore fluid builds up within the ear, and this fluid, as you can imagine, if you're trying to hear, we have the eardrum, and the eardrum vibrates, and the eardrum, if there's fluid, sticky fluid in the middle ear, and it's vibrating against that sticky fluid, there's going to be a dampening of the vibrations. So this in turn will affect James' hearing. He's not going to hear as well. And this effectively causes a vacuum within the middle ear, because the air pressure, it's not well balanced, and the tympanic membrane is indriven. So that's very important to pick up when you're looking in the ear. Otitis media with infusion will cause an indriven tympanic membrane. And of course, James Muller is very concerned. She wants to know what the management is. And you explain that, you know what, you're not going to do anything for the next 3 months. And initially, James Muller is quite stressed by this. So you clarify that, in fact, in 3/4 of children, the symptoms will resolve within 3 months. And if they don't resolve within 3 months, you may consider a grommet insertion. And this grommet is simply a tube that's inserted into the eardrum, and it will drain all this fluid off the middle ear. And most come out after 9 months. So it's not like the child will have it for life. They do come out, and they are very effective. And you do go in and present this case to a GP in your practice, because you are only a GP trainee at this stage, and he asks you what would happen if an adult had otitis media with infusion. And you say it's very rare for an adult to get this condition, and they can get it if they have been flying. But if an adult has a glue ear, you must refer to a specialist to investigate for postnasal tumour. And the GP is very impressed with your answer and impressed with your management of James, and that really concludes this case. You have given James and his mum an information sheet as well, and they know that it should resolve within 3 months. So thank you very much for listening. Please hit the like button, share and subscribe to this channel, and don't forget to check out the other videos.